Sir, as we know that the atrial fibrillation is the commonest arrhythmic disorder worldwide that you must have experienced in your practice also as well. But if we talk about the registry and incidence part of the atrial fibrillation, it seems to be around 1.8 to 2%. And this is the overall consensus is that this is the disease which remains since so many years it remains underdiagnosed. So sir, you have such a wide experience in the cardiology field. So what is your experience on this particular disease and its detection rate in your practice as well?
From past say 50 years, and I entered as a student of undergraduate in Madras Medical College. From then onwards, as a clinical studies, clinical side, I have been experiencing this kind of this disease that is called atrial fibrillation, and for a long years. Those days, atrial fibrillation means irregular heartbeat. The patient is having a, we used to think that it is due to the rheumatic mitral valve disease, and then we used to give the digitalis and digoxins daily 5 days in a week, and then we will treat the patient. So that is the scenario existed 50 years back. So later on, what had happened, this atrial fibrillation is causing this digitalis therapy in atrial fibrillation, either in a rheumatic mitral stenosis. First cause of atrial fibrillation was detected among the practitioners, the doctors, they are thinking. Then they found out lone atrial fibrillation. The atrial fibrillation in the heart, we are not able to detect any disease, the lone atrial fibrillation. In that scenario also, we are giving the digitalis. This may occur in a middle age and also old age. So then later period of years, we have found out then the hypertensive heart disease in elderly, say age of 60 or 70, they used to present a picture of atrial fibrillation with a varying ventricular rate. The atrial fibrillation passed, when then it comes, then also what happens, then we have started giving the same digitalis in the 60s and 70s. Then after that, the treatment is little bit modified, and then we started giving the isoptine. So isoptine was started giving, then the beta blockers has come as a treatment. Then the later period, then the antiarrhythmic drugs has been revolutionized. Then various antiarrhythmic drugs came into the field. Then we started giving. The main reason for atrial fibrillation in a normal heart, in a valvular disease, and also in the lone atrial fibrillation without any heart disease, then hypertensive heart disease, and elderly people without any disease, they may develop the atrial fibrillations. Then elderly people invariably they will have hypertension, they will have a atherosclerotic coronary artery disease, where they may have mild ischemia or a major myocardial infarctions and cardiac failure. This is the scenario has been and well established in the late 80s and 90s. Then they found out that the atrial fibrillation no use. This is given in valvular disease in the period of 60s, 50s, 60s and 70s. Then they started isoptine. Then they started giving the beta blockers. Then beta blockers usually they are given the Inderal and other things. So then there is, when they found out the why the atrial fibrillation has started, and then there are a lot of in a mitral stenosis, left atrial enlargement. So the atrial fibrillation, when the atrium is enlarged, then they may produce a ectopic focus in the atrium. Then the heart rate is increases, atrial rate increases enormously more than 200, they go for flutter and fibrillations. So the atrial, the reason for the atrial fibrillation, they found out the enlarged left atrium. So if they enlarge left atrium, what happened? It is fibrillating, it is not contracting and it is not releasing the blood to the left ventricle. So it is only fibrillating. Since there is a fibrillation occurs, so what happened? The stasis of the blood occurs in the appendix, left atrial appendix. Left atrial appendix is it's not an important part in the atrium, left atrium, it is one appendix, it is one like a pocket, side pocket. So, in that scenario, what happens, this fibrillating heart, that atrium, the blood stays in the appendages. So, whenever the blood stays, there is a tendency to thrombus formation. So, usually the work of the blood that has to be going on running. It must be in the circulation. Then only it may supply to the various parts in the body, starting from up from the head to the down to the toe. So, that is the main nature of the blood. So, whenever the blood stays staying without any flow, then there is a tendency of clotting. So, that occurs in a case of atrial fibrillation, and especially the left atrial site, where there is a left atrium is not doing any work. This is a pouch. So, there is a blood is staying, the blood pumps. Even the normal heart, whenever there is a rhythm is controlled, then left atrium thrombus forms from the left atrium. When there is a fibrillating means the atrium is not really doing its work. So, the thrombus migrate from the left atrium into the ventricle and spills over to the mainly to the circulation. When it comes to the circulation to the left atrium, left ventricle, to the aorta, then nearest vessel which is going to the carotid artery to the brain. The stroke occurs in the brain first, the right or left. So, especially in the case of elderly people. And so, this mechanism occurs either only the atrial fibrillation, the fibrillating left atrium and then perpetuate the thrombus migration from the appendix, which is already formed. So, down to the atrium and comes to the left ventricle and goes to the aorta, and near first branch which comes to the arch of aorta is the carotid arteries, left and right. So, that easily thrombus forms like this. So, that is the situations. Now, we have spectrum of disease we have seen which is producing the atrial fibrillation. So, atrial fibrillation occurs in the normal heart also. It may occur in the valvular diseases in the younger and middle aged people. Rheumatic valvular diseases are common. Even rarely it occurs in the aortic valvular disease. Aortic stenosis may also produces atrial fibrillations. And also because these two conditions, mitral stenosis, left atrium enlarges. So, when there is enlarged, then there is when thrombus forms in the left atrium or in the appendix. So, then it is aortic stenosis. What happens? There is a stenosis of the aorta, outflow tract. So, left ventricular hypertrophy. When the hypertrophy occurs against the left ventricular pressure, the atrium has to contract. So, atrial pressure also increase. That also then the reason it does for thrombus formation. So, one is mitral stenosis in younger group, rheumatic heart disease, and second is aortic stenosis. Aortic stenosis is acquired aortic stenosis occurs in the case of elderly people, sclerosis of the aortic valve. That is why the elderly people commonly get the strokes over the age of 50. So, we will also teach the student, and then the patient is having coronary artery disease, is ongoing process, degenerative diseases occur in the coronary arteries and cerebral arteries and also atherosclerotic aorta also. So, these arteries which are there, and then the stroke will only mainly come to the brain, especially from the thrombus from the left atrium. Whereas, in the case of coronary artery, only coronary thrombus occurs. So, in this situation, first elderly individual, hypertensive and aortic sclerosis, and also will having these are all the conditions. And also there is a ischemic heart disease, the left ventricular failure, and then the atrial also is having to contract forcefully, and also myocardial infarction, ischemic heart disease is acute or chronic, and then cardiomyopathies. There is a big heart, enlarged heart. In that situation also atrial fibrillation starts. So, these are all the certain scenario, and the peripheral, then ladies will get also atrial fibrillation when after the peripheral phase, that is after the delivery, their heart also enlarged. Then they may also produce a atrial fibrillation. And idiopathic atrial fibrillation, nothing. Young people may like to get atrial fibrillation. So, fibrillating heart and then fibrillating atrium, and always a need for the thrombus formation in the appendix. Then when there is fibrillating, the flow of the blood is suddenly comes when down to the ventricle without any contractions. So, automatically thrombus also from the left atrium pass to the left ventricle. So, this is the mechanism, and this condition when it occurs, first I told you that digitalis is a drug of choice. Then we have gone for beta blockers, and isoptenase we started giving related atrial arrhythmias, especially the atrial fibrillation, atrial flutter. So, now the revolutionized treatment and come with various antiarrhythmic drugs has come, and cardrone, so on and so forth. So, even we can treat the antiarrhythmic arrhythmia with antiarrhythmic drugs, atrial fibrillation, but the sequelae of the atrial fibrillation, that is thrombus formation, migration of thrombus, stroke we have to avoid. Then existing thrombus in the left atrium, that is in the appendix, how to prevent. So, you need to dissolving the thrombus, dissolving drugs which are needed. So, we started giving the intravenous that is in the thrombus dissolving drugs like streptokinase, urokinase, tissue plasminogen activators, anectoplase, so on and so forth. Then low heparin, unfractionated heparin, and also low molecular heparin, and pandronoprax, and bivalirudin also started giving it. So, how long you will give a needle? Only a short time, say acute phase you will give, even a stroke patient. Then what will happen? Stroke patient, that formation of thrombus is ongoing for a longer period. So, you have to prevent. So, how long you will give for a shorter time, say of 10 days, 15 days. Then later you have to go on with the oral antithrombotic, that is coagulants. The oral anticoagulants, we had already one of the drugs is called the syndrome, that is in the acetone. Acetone, when you start taking acetone, you have to see the INR, isn't it? Yeah. INR must be 1.5 into 2 or 2.5 must be there. That is a menace. You have to check the INR frequently, always for the patient, when they have to take the blood and test, and then investigation. But testing, the cost is more higher, and when the patient is diagnosed in the case of thrombus solving acetone. So, another drug, new drug has come, which is called the dabigatran. Dabigatran is costlier, and also dabigatran started giving a problem, and also not only cost very, very highly costly, and also there is a thrombus formation, that is in the bleeding also occurs some cases. Some cases also it is contraindicated kidney diseases. Whereas another drug of choice has come, is called the rivaroxaban and oxaban. So, which are all the new entrants of the anticoagulant. So, which are all more effective and also patient friendly, and also there is no need for the frequent checking of INR, and patient is having a menace going to the lab and taking frequently, then spending more money. So, this drug will be taken once in a daily or twice in a daily in a case of acute situations, and once in a daily, and as the physician desires and sees the clinical outcome of the patient, he can continue the drugs for as long as possible. So, this is the new anti-thrombotic, there is a thrombotic drug. This is supposed to be used, and also other uses in the drug, not only from atrial fibrillation with thrombotic reasons, and also in the case what happened, whenever I told you earlier in my speech, whenever the blood slows down and also it goes very slowly in the circulation, then there is or stasis occurs, there is a tendency for clogging. If you see the river bed, the water is flowing clearly as long as it takes all the mud and all the dust and all. When there is a slowly flowing, all the dust accumulate and water has become thicker. Same mechanism occurs when there is a slowdown of the blood circulation occurs. So, thrombus forms. So, for which also we can give instead of that is will be antithrombotic, we can give prevent the thrombus in the lower limbs, deep vein thrombosis, and also in the cases long standing bedridden patients like stroke, already stroke is we are getting it, and also the knee transplant, and also coma and other conditions, morbid conditions where we are supposed to see the all these legs are all kept stretched without any circulation will be slowed and then thrombus formed. In that situation also we can give this oral anticoagulant.
So, rightly mentioned you sir said that the way you have described from the beginning that how the from your education background also as well, that when you were as a student, arrhythmic disorders, atrial fibrillation means irregular of heart beating, then how the concept of the arrhythmic disorder has come, then initial from digitalis you have shifted to the modern antiarrhythmic drugs to control the rate and rhythms, and also in part of the stroke you explained very well that how the stasis of blood is happening in the left atrium, and then this stasis leads to a clot formation, that thrombus will transport to the left atrium, and ultimately it goes major chance to goes to the brain and leads to a ischemic stroke. And definitely stroke, you mentioned that it's one of the commonest risk factor when patient is developing atrial fibrillation. It's almost 4 to 5 times higher chance as compared to the non-AF patient, and so the primary prevention of stroke is always better option than the secondary prevention. And you also mentioned regarding the conventional older oral anticoagulants and what is the role of the newer oral anticoagulants, and what are the current challenges with the VKs like the INR prothrombin monitoring and the drug-drug interaction, and leads to various kind of the INR levels, and which leads to either bleeding or ischemic recurrent kind of the stroke. So, NOACs are definitely better options, dabigatran, rivaroxaban and apixaban, and they are also can be used in other indications like the other thromboembolic disorders like deep venous thrombosis, pulmonary embolism, and prolonged bedridden patients who is going for the hip and knee replacement of the surgery. So, here I think sir has given the very good opinion and suggestion on this particular therapeutic area of atrial fibrillation and oral anticoagulant. So, we are sir very thankful for your all the expert opinions and your comments, and we are very grateful for your valuable time.
Because this new found this oral anticoagulant therapy is essential, because only thing maybe there so many things will be there. First to come always it will costlier, and later it will be also settled. It will come down the price level also when the market is become very large, and then a lot of lakhs and people are started. Comes that the company can able to reduce the price also. So, that in my experience what I am telling, when the price is in another indication also, when I as a cardiologist, as intervention cardiologist, so I used to treat the patients in the angioplasty with the stenting. So, when I used to treat the patient with angioplasty with stenting, there is a chances of thrombus formation in the periprocedural. Periprocedural means when we are deploying the stent in the coronary artery, that time that the thrombus may form. So, that then after the procedure, then the patient is 24 hours in the monitoring, that also, that period also the patient will have a thrombus formation. I have to mention this point, whereas there is a patient is having acute myocardial infarction or acute coronary syndrome, whereas the blood is thrombogenic. Yes. That is a major things, the burden of thrombus formation, and also there is occur instant thrombosis and subsequent cardiac failure, cardiac arrest occurs during the procedure of the intervention. So, then we have to take care, and then you have to give the well prepared the media of the blood. That is, as I told you earlier, there is a arrhythmogenic, that is in the thrombogenic blood. This is a thrombogenic blood. The thrombogenic blood you have to convert into it is equally non-thrombogenic. So, you have to add the aspirin and also clopidogrel, and in addition, and these drugs are given and loading dose in the early period, say 3 hours or 6 hours before the angioplasty. So now I have decided to add also this oral anticoagulant, which is newly introduced. Why not we give smaller or combination dose of the triple therapy before the procedure and also following the procedure, later on the procedure. What the intervention, the peri-procedure and also immediately after 24 hours, there is a thrombus formation. And after the thrombus formation, one day, then you have to observe him for a week. So when there is also a tendency for thrombus, may not occur if you have a precautions, then you take after 1 week and per month, there is a dangerous period. The subacute thrombus may occur. So these kind of situations, so like to use this newer anticoagulant such as the rivaroxaban, and like to give my experience later period, subsequently follow up with some patients. So that is also possible, and now right now we can start with the triple therapy following the angioplasty. So aspirin with the clopidogrel and also with rivaroxaban. So we will have to follow it for a month, because here you have to choice of the physicians, his experience of the intervention, how many cases done, how many complications come across during the peri-procedure and the post-procedure. It is not like that. You have to say and you have to prepare. 90% it can come out, 99% it come out successful. Because in my experience for 20 years in the intervention and preparing the cases, and go ahead with all these precautions and also comorbid conditions, and also in a good laboratory where the high volume performance is done, so we can come out successfully.
Sure.
Thank you.
So surely that is also a nice thought of that use of oral anticoagulants along with dual antiplatelet, in specific the peri-procedural complications of the stent thrombosis and all that. So thanks Dr. Arthnari sir, and for your all the valuable comments and your such a wide experience what you have explained during the this talk. It's definitely so valuable. So it's a very honor for us. Thanks.